Bismillahirrahmanirrahim. Today we will have case quiz number 35. Case data: 44 years old female developed Raynaud's phenomenon and joint pain 8 months ago. The latter, joint pain, responded to non-steroidal anti-inflammatory drugs. Over the last few months, she had noticed that the skin over the fingers becoming tighter. In recent weeks, she had developed muscle weakness such that she finds it difficult to climb stairs or get out of a chair unaided. By examination, she had some skin tethering over the fingers with reduction of the finger bulbs, tender joints, but no objective evidence of synovitis. Proximal muscle power is reduced to 3/5 scale. Respiratory examination revealed bibasilar fine inspiratory crackles. By investigations, the ANA was positive both by ELISA and immunofluorescence. ANA profile showed only positive anti-U1 RNB, with all of the other are negative. And finally, polyclonal hypergammaglobulinemia, which is positive in this patient. So to summarize, the patient has history of only 8 months with progressive skin thickening, bibasilar fine crepitation, muscle weakness, joint pain with no objective evidence of synovitis, ANA positive with positive anti-U1 RNB, and polyclonal hypergammaglobulinemia. So, what is the diagnosis? The answer is, of course, mixed connective tissue disease. What is mixed connective tissue disease? This female patient has presented with a combination of features seen in RA, SLE, myositis, and scleroderma in the presence of anti-U1 RNB antibodies. So the most likely diagnosis is mixed connective tissue disease. Whether mixed connective tissue disease remains a truly distinct clinical entity is somewhat controversial, and many patients may eventually develop sufficient features to fulfill established diagnostic criteria or classification criteria for a particular autoimmune disease. The case presented here highlights the most common presenting features for mixed connective tissue disease, including joint symptoms, Raynaud's phenomenon, sclerodactyly, and proximal myopathy. Other frequent problems include esophageal dysmotility, serositis, and lymphadenopathy. Although respiratory involvement is common in mixed connective tissue disease, it is often asymptomatic. This patient has a fine bibasilar crepitation, which is suggestive of interstitial lung disease. She will need a chest X-ray and possibly a high-resolution CT scan to identify interstitial changes, as well as lung function studies to quantify any restrictive defect or reduced gas transfer. This will be done by diffusion capacity tests. Management of mixed connective tissue disease involved directing therapy to a specific abnormalities. The treatment for each clinical feature in the combination is identical to that for a given presentation in isolation. For example, vasodilators for Raynaud's phenomena, hydroxychloroquine for arthralgia, and corticosteroids for myositis. Over time, the inflammatory component and the severity of mixed connective tissue disease manifestations generally diminish. Pulmonary hypertension is the leading cause of death in these cases. And finally, thank you very much for your attendance. and see you tomorrow with case quiz number 36. Wassalamu alaikum wa rahmatullahi wa barakatuh.